to talk about the joint occurrences of traumatic brain injury and dementia, as well as some of their treatments. So along with traumatic brain injury, or TBI, is how I'm going to refer to it from now on. It is typically caused by an injury to the head or neck. These injuries include impacting your head off the surface, such as like falling, hitting your head, or penetration of the skull and brain, which can result from like shrapnel or other hard objects. And then whiplash, which is sudden movement of the head back and forth, and that can cause the brain to move in the head, which will result in a TBI. TBI is a very prevalent occurrence in the United States today. So it occurs more than any other diseases, such as cancer, Parkinson's disease, or MS. So it's really important that we educate people on how TBIs occur, some of the symptoms to look for, and other like treatments or preventative measures, so that later down the road there aren't other extraneous problems that are associated with it. So some of the underlying pathology of TBI. In the first 60 minutes after you sustain a TBI, there is an increase of glutamate, which can be seen right here in this graph. So the dotted line is baseline, and this is comparing it to baseline. So it increases, and it is increased from the presynaptic terminals, and it disrupts the postsynaptic membranes, and it alters the equilibrium. So glutamate is the most abundant neurotransmitter in the brain. It is involved in learning and memory. There's also an increased amount of potassium released, and that can be seen right here in this blue line, this big peak. The amount released is dependent on the severity of the injury. So the more severe the injury, the higher amount of potassium that will end up being released. This alters the ion balance, and in order for cells to be able to fire again, they must return to equilibrium, which is fueled by ATP, a cellular energy molecule. And then there's also an increase in calcium with this big green line here. And this calcium will accumulate, and it overloads the mitochondria. So the mitochondria are trying to uptake and get rid of the calcium, but there's too much, and it causes oxidative stress, which then causes the mitochondria to misfunction. So all of these can change in how free radicals form and glucose metabolism. So with this, glucose, it is an important molecule because it aids in the formation of ATP, which is essential for cellular energy. In a rodent model from a study done, in the first 30 minutes after a TBI was sustained, there is an increase in cerebral glucose. So it's kind of hard to see because it happens so quickly, but there's a line right here in all these types of injuries that spike all the way up. But then sometime after, it drops down to a really sudden depression in the ability to be able to metabolize glucose. So cerebral glucose metabolism is essentially the process of metabolizing glucose in the brain. So it is thought that this happens because energy is needed to restore equilibrium of the ion balance in the brain. So that's why there's a sudden increase. But then the depression has been noted to cause an energy crisis in the brain. So it is possible that this happens because there is an impairment in cerebral blood flow. So blood isn't flowing properly throughout the vessels in the brain, not allowing glucose to travel. So dementia is a symptom typically associated with neurodegenerative diseases such as Alzheimer's disease, Parkinson's, ALS, and many other diseases. So some of the symptoms that occur with dementia is loss of memory, decreases in language production and comprehension, recognition of objects and faces, and potentially some personality changes. Alzheimer's disease and frontotemporal dementia are two forms of dementia that affect different areas of the brain. They're both very prominent forms of dementia that can occur. Common factors that are seen in dementia is old age and cell death, as well as injuries such as stroke or tumors. The underlying pathology of dementia is really interesting because it relies a lot on protein accumulations or aggregates. So there are certain proteins that will cause plaques or tangles, and that plays a large role in neurodegeneration that will lead to dementia. So the first protein I'm going to talk about is amyloid beta precursor protein. This is a protein that is essential for neuronal repair and growth, and the accumulation of this mutation, or mutation of this protein can cause neurodegeneration and dementia. It is also associated with Alzheimer's disease. Next, alpha-synuclein. It is another protein that is found in the presynaptic terminals of neurons. It is believed to be involved in the clustering of synaptic vesicles, which are important for the release of neurotransmitters. It is also speculated to be involved in dopamine release, so mutations of this protein are known to cause Parkinson's disease, which is another neurodegenerative disease associated with dementia. And then the last protein I'm going to talk about is tau. This protein is found in microtubules, and it's a stabilizing protein. It helps with the main structural support of neurons. So tau can become overphosphorylated, which causes it to form clusters or tangles. And this protein can cause dysfunction, and it is associated with Alzheimer's disease, frontotemporal dementia, and it even has some Parkinsonism, Parkinson-like diseases, or symptoms, Next, vascular dementia is a really interesting form of dementia. So it is a result of cerebrovascular dysfunction, which basically means that the blood isn't traveling throughout the brain correctly. So this is the second most common cause of dementia. It can be presented as cortical, so on the surface of the brain, or subcortical below, and it is presented as infarcts, which is just a small area of dead tissue that is a result from a lack of blood flow. So underlying heart disease is also a major factor in vascular dementia, so there can be problems with the arteries, the stroke, other things can happen that can cause vascular dementia. So there's a lot of speculation about why TBIs lead to dementia. So TBIs have been thought to cause an acceleration of neurodegenerative diseases that cause dementia, such as, like we've already been talking about, Alzheimer's, Parkinson's disease, so on. It is the best known epigenetic risk factor for dementia. A meta-analysis showed that about 50% of the people that have sustained a TBI are at a greater risk for developing dementia down the road. They looked at World War II veterans that lost consciousness during TBI, and those veterans had a 4 times risk increase of developing dementia. And then furthermore, it isn't uncommon for an athlete such as like a boxer to sustain multiple or repetitive TBIs, and this can cause something called chronic traumatic encephalopathy. And this is a neurodegenerative disease that's typically caused because of head trauma. And it can lead to dementia down the road because of the repetitiveness. So, furthermore, TBI is a risk factor for Parkinson's disease. There are formations of the aggregates known as Lewy bodies. These are in the substantia nigra, which is a structure that plays a role in movement and has a large amount of dopaminergic neurons. So there is a lot of neurons lost in this structure in regards to neurodegeneration, and there's also a large loss of dopamine, and this can be seen to cause rigidity in patients as well as dementia, which are both hallmarks of Parkinson's disease. Also, there is an increase of protein alpha-synuclein, which it is observed in brain tissue, and TBI patients are more at risk with dementia if they have increased alpha-synuclein for a large amount of time. And even though I already talked about reoccurrence of TBIs, a single TBI is already an epigenetic risk factor for dementia, such as like Alzheimer's type dementia. Research has shown that there's a pathological link that a single TBI and the onset of Alzheimer's-like dementia is increased in patients that were seen to have amyloid plaques. About 30% of those died following a TBI, and after examining the brains, there was a large increase of the plaques. So this plaque buildup was rapid rather than a later onset. And then another study that focused on older athletes, there is a comparison group of athletes who had TBI in the past, which is the white column, and then athletes who never had a TBI, the black column. So in a study done on these retired athletes, it showed that there was a trend of decline in their brain function. So these athletes were compared to the retired athletes that sustained no concussion. So the athletes had TBIs in the past had a much higher risk of developing dementia and already had other functional problems. So compared to the control group, there is problems seen in episodic memory, frontal lobe functions, and motor execution. And then this graph shows that there's a difference between athletes with a history of concussions and those without. It measures the range duration of the velocity of dominant hand versus non-dominant hand in single and both hands. So the athletes that had a TBI in the past underperformed every single time compared to those that did not. And then the results also had statistical significance backing them up. So I just wanted to briefly talk about the epidemiology of TBI and dementia. So mild TBI patients living in life are likely to have diabetes, coronary artery disease, a history of alcohol intoxication, stroke, lower socioeconomic status, and many other things. But in a study, with a total of 1,071 people that were diagnosed with TBI, 127 of those patients had prior TBIs, which is about 12% of that population of people. The figure at the right shows a hazard ratio of dementia between a control group, the blue, and a group that has suffered a mild TBI, the red or purple looking one. So you can see that over time, after incidence, there is a great increase of the risk of forming dementia. So treatments for TBI, there isn't anything too crazy. So first, behavioral intervention is commonly seen. People that are able to treat TBI, they use something called the ABC, which stands for antecedent behavior and consequence. So it is a method to perform functional assessments of someone that had a TBI so that you can see how they're acting before, during, and a little bit after what happened. So problem solving has also been emphasized as important in behavioral intervention, as well as simply listening to the patient. So like getting to be able to hear what they're talking about, if they sound slurred, other stuff like that. This is really important in older patients too that fall and hit their head. And then there's also medications that can be used. This can help increase intention, decrease anxiety, help with pain. And then older patients have a lot of sleep deficits, so that can help with that as well. And then just the typical resting. If you have a TBI that's not so severe, rest and get better, let your brain heal itself. And then as for treatments for dementia, there's a lot of treatments under research. One that I just found interesting was music therapy. So this has been shown to have benefits and some negatives, but mostly the benefits outweigh. So it can help reduce anxiety, depression, as well as some cognitive functioning, such as increasing immediate memories and other stuff. It's also safe and a low-cost treatment. But then there's also medication. So in a study done comparing different medications, there is an anti-dementia medication and then a nootropic medication. So a nootropic medication is basically a medication that will help enhance memory and cognitive functioning. So those with dementia that had no treatment had the worst fatality or survival rate. I'm sorry. And then adding the nootropics increased that. But anti-dementia medicine did better compared to the nootropics. But in a combination of the anti-dementia medication and the nootropics, they had the best survival rate out of all. And the black line is a baseline with patients with no dementia. And then as for joint treatments, I couldn't really find anything in the literature for joint treatments. So I guess I wanted to pose the question as what you could speculate yourself, because like thinking about it and reading about it, I don't know how it would occur, but I think something that could help ease the amount of chemical imbalance in the brain and help relax the mitochondrial overloading is something that can be used to help prevent free radicals from forming and eventually the onset of dementia later in life. So that is all that I have for you. If you have any questions, I will take.
Questions? So remember that content from these presentations can come up on the exam. So if you didn't understand something, please ask. All the slides will be posted on Moodle as well. But if there's something that was said that you're a little unclear about, now's your chance.
You said that there were higher instances of diabetes, alcohol abuse, and lower socioeconomic class, as far as people with even mild TBI. Do you have any idea why those are connected? Is it something where people in a lower socioeconomic class are experiencing more head injuries, or is it afterwards, after they get the trauma, they wind up in a lower socioeconomic class?
It was kind of the way that I interpreted it. They already had lower socioeconomic status, so it's potential that maybe education played a factor in how to treat yourself, or like to seek out medical treatment and other stuff like that. And then with the onset of diabetes, could be due to old age. The alcohol was interesting. I couldn't really find a reason why, but it was, I thought, an interesting fact.
Others? All right, Caitlin, I have a question for you. Could you go back to some of your slides at the beginning where you had changes? So the calcium slide, for example, I think that's like your second one or so. Okay, can you speculate why you see an increased release of calcium following a TBI?
Calcium is used a lot in the firing of neurons, so it helps excite the presynaptic neuron. So I guess the large increase can be a result of neurons firing after the injury to try and fix itself, maybe, or...
Okay, but where would that release come from? Because the calcium is inside of the cell when it's causing the neuron to fire. So it's normally outside of the cell in a high concentration. So where does that extra calcium come from?
Then it might be coming from in the neuron, is being processed out, which maybe then is a lack of firing.
Okay.
Because the neurons would be excited.
Okay. And then another question. Go to your glucose metabolism slide, like next one or two on down. Yeah. So you said something to the effect that energy is needed to restore ionic balance. What specifically are you talking about with that?
So, like I said, ATP is a molecule for energy, cellular energy. So, in order for there to be energetic action, such as neurons firing, you need to be able to metabolize glucose, which is really big in energy. So, if your brain is struggling to metabolize it, then you're going to have a lack of energy, not be able to produce ATP in the brain, and this can cause a lack of firing and other problems.
Okay, but what specifically do you need that energy for to help restore ionic balance? So this would be like after the injury when you're trying to fix things. What is that? How is the ionic balance being maintained or restored?
So if you if you have an injury and you need medication or other stuff, glucose metabolism is important in helping cells get the energy they need to repair themselves, or other factors such as just the neurons firing.
Okay, what are they doing though, specifically? So I'm asking you for a mechanism. So how would the ionic balance be maintained or be restored?
Like in a homeostatic response?
Well, following injury, how do you get back to normal?
Medicate,
Not medication, no, within the cell. Because
In
he
the
said
cell.
he said the energy is used for ionic balance. How does the cell use that energy? What specifically is it using the ATP for?
It's breaking it down and using it
To do what?
gosh, I know I know this. It's breaking it down and using it to help, is it with the release of the neurotransmitters or?
Could be used for some of that, yeah.
Yeah.
That wouldn't necessarily maintain balance though. But we'll drop it for time.
Okay.
So, Caitlin just has the bad luck of being the first person up, okay? I'm gonna ask everybody questions about the content you have. She's not losing points because she doesn't have an answer. That's okay, all right? I don't expect you to know all the answers for these things. I want you to be able to speculate, to reason through the problems of the materials you print forward. So, you're doing that, so that's good. Okay, any other questions? All right, we are done. Thank you very much, Caitlin.